The presynaptic neuromuscular nerve ending contains membranous vesicles prepared to release its stored neurotransmitter, acetylcholine. Neuronal stimulation initiates a cascade of events that leads to the fusion of the neurotransmitter-containing vesicle with the nerve membrane. This process is facilitated by interaction between proteins on the vesicle and on the cell surface, which together form the snare complex. The membrane fusion results in the release of acetylcholine into the synaptic cleft by a process of exocytosis. The acetylcholine diffuses across the synaptic cleft and eventually binds to receptors on the muscle, leading to muscle contraction. This illustration represents a muscle in the body. Note the motor neuron extending into the muscle and the sensory neuron extending out of the muscle. When Botox, OnabotulinumtoxinA, is injected, it is expected that most of the neurotoxin would remain in the area of injection. Eventually, the Botox core 150 kilodalton molecule dissociates from the surrounding protective accessory proteins. The binding domain of the Botox core molecule is the C-terminal portion of the heavy chain, which interacts with receptors on the nerve terminal. The Botox core molecule enters the nerve cell by a process of receptor-mediated endocytosis. The toxin is now contained in a membranous vesicle inside the cell. The light chain is then released into the cytoplasm of the nerve terminal, where it is available to cleave the snare proteins. In motor neurons, the light chain of the Botox core molecule blocks the release of acetylcholine by cleaving SNAP25, which is an essential component of the snare complex. When acetylcholine cannot be released, muscle contraction cannot occur. In sensory neurons, the light chain is believed to cleave SNAP25 by a similar mechanism, thereby blocking the peripheral release of neuropeptides, which reduces the sensitization of pain nerves. The exact mechanism of action is unknown. The toxin does not appear to affect the conduction of electrical signals along the nerve fiber or the synthesis or storage of acetylcholine. Indications: upper limb spasticity. Botox for injection is indicated for the treatment of upper limb spasticity in adult patients to decrease the severity of increased muscle tone in elbow flexors, biceps, wrist flexors, flexor carpi radialis and flexor carpi ulnaris, and finger flexors, flexor digitorum profundus and flexor digitorum sublimis. Important limitations. Safety and effectiveness of Botox have not been established for the treatment of other upper limb muscle groups or for the treatment of lower limb spasticity. Safety and effectiveness of Botox have not been established for the treatment of spasticity in pediatric patients under age 18 years. Botox has not been shown to improve upper extremity functional abilities or range of motion at a joint affected by a fixed contracture. Treatment with Botox is not intended to substitute for usual standard of care rehabilitation regimens. Cervical dystonia. Botox is indicated for the treatment of adults with cervical dystonia to reduce the severity of abnormal head position and neck pain associated with cervical dystonia. Blepharospasm and strabismus. Botox is indicated for the treatment of strabismus and blepharospasm associated with dystonia, including benign essential blepharospasm or seventh nerve disorders in patients 12 years of age and above. Important safety information. Distant spread of toxin effect. Post-marketing reports indicate that the effects of Botox and all botulinum toxin products may spread from the area of injection to produce symptoms consistent with botulinum toxin effects. These may include asthenia, generalized muscle weakness, diplopia, ptosis, dysphagia, dysphonia, dysarthria, urinary incontinence, and breathing difficulties. These symptoms have been reported hours to weeks after injection. Swallowing and breathing difficulties can be life-threatening, and there have been reports of death. The risk of symptoms is probably greatest in children treated for spasticity, but symptoms can also occur in adults treated for spasticity and other conditions, particularly in those patients who have underlying conditions that would predispose them to these symptoms. In unapproved uses, including spasticity in children, and in approved indications, cases of spread of effect have been reported at doses comparable to those used to treat cervical dystonia and at lower doses. Contraindications. Botox is contraindicated in the presence of infection at the proposed injection sites and in individuals with known hypersensitivity to any botulinum toxin preparation or to any of the components in the formulation. Warnings and precautions. Lack of interchangeability between botulinum toxin products. The potency units of Botox are specific to the preparation and assay method utilized. They are not interchangeable with other preparations of botulinum toxin products, and therefore units of biological activity of Botox cannot be compared to or converted into units of any other botulinum toxin products assessed with any other specific assay method. Spread of toxin effect. See boxed warning. No definitive serious adverse event reports of distant spread of toxin effect associated with Botox for blepharospasm at the recommended dose, 30 units and below, or for strabismus at the labeled doses have been reported. Hypersensitivity reactions. Serious and/or immediate hypersensitivity reactions have been reported. These reactions include anaphylaxis, serum sickness, urticaria, soft tissue edema, and dyspnea. If such a reaction occurs, further injection of Botox should be discontinued and appropriate medical therapy immediately instituted. One fatal case of anaphylaxis has been reported in which lidocaine was used as the diluent and consequently the causal agent cannot be reliably determined. Dysphagia and breathing difficulties in treatment of cervical dystonia. Treatment with Botox and other botulinum toxin products can result in swallowing or breathing difficulties. Patients with pre-existing swallowing or breathing difficulties may be more susceptible to these complications. When distant effects occur, additional respiratory muscles may be involved. See boxed warning. Pre-existing neuromuscular disorders. Individuals with peripheral motor neuropathic diseases, amyotrophic lateral sclerosis, or neuromuscular junctional disorders, for example myasthenia gravis or Lambert-Eaton syndrome, should be monitored particularly closely when given botulinum toxin. Patients with neuromuscular disorders may be at increased risk of clinically significant effects, including severe dysphagia and respiratory compromise from typical doses of Botox. Pulmonary effects of Botox in patients with compromised respiratory status treated for spasticity. Patients with compromised respiratory status treated with Botox for upper limb spasticity should be monitored closely. Corneal exposure and ulceration in patients treated with Botox for blepharospasm. Reduced blinking from Botox injection of the orbicularis muscle can lead to corneal exposure, persistent epithelial defect, and corneal ulceration, especially in patients with seventh nerve disorders. Retrobulbar hemorrhages in patients treated with Botox for strabismus. During the administration of Botox for the treatment of strabismus, retrobulbar hemorrhages sufficient to compromise retinal circulation have occurred. It is recommended that appropriate instruments to decompress the orbit be accessible. Bronchitis and upper respiratory tract infections in patients treated for spasticity. Bronchitis was reported more frequently as an adverse reaction in patients treated for upper limb spasticity with Botox 3% at 251 to 360 units total dose, compared to placebo 1%. In patients with reduced lung function treated for upper limb spasticity, upper respiratory tract infections were also reported more frequently as adverse reactions in patients treated with Botox 11% at 360 units total dose, 8% at 240 units total dose, compared to placebo 6%. Adverse reactions. The following adverse reactions to Botox for injection are discussed in greater detail in the following sections. Spread of toxin effect, see boxed warning. Hypersensitivity reactions, see contraindications and warnings and precautions. Bronchitis and upper respiratory tract infections in patients treated for spasticity, see warnings and precautions. Upper limb spasticity. The most frequently reported adverse reactions following injection of Botox for upper limb spasticity include pain in extremity, muscle weakness, fatigue, nausea, and bronchitis. Cervical dystonia. The most frequently reported adverse reactions following injection of Botox for cervical dystonia include dysphagia 19%, upper respiratory infection 12%, neck pain 11%, and headache 11%. Blepharospasm. The most frequently reported adverse reactions following injection of Botox for blepharospasm include ptosis, 21%, superficial punctate keratitis, 6%, and eye dryness, 6%. Strabismus. The most frequently reported adverse events following injection of Botox for strabismus include ptosis, 15.7%, and vertical deviation, 16.9%. Post-marketing experience. There have been spontaneous reports of death, sometimes associated with dysphagia, pneumonia, and/or other significant debility or anaphylaxis after treatment with botulinum toxin. There have also been reports of adverse events involving the cardiovascular system, including arrhythmia and myocardial infarction, some with fatal outcomes. Some of these patients had risk factors including cardiovascular disease. The exact relationship of these events to the botulinum toxin injection has not been established. Please see accompanying full prescribing information, including medication guide.